Can I kindly welcome you all to the oral session 8 of National Conference of Epidemiological Foundation of India 2020 organized by All India Institute of Medical Sciences. I would like to introduce our eminent chairperson, Dr. Manisha Nagpal, MBBS MD, Professor in Community Medicine at FGRD. She has 16 research publications and has authored two chapters in the books entitled Advances in Health and Diseases and Challenges in Disease and Health Research. She has done many courses in medical education technology. She has also done certificate course in research methodology from Indian Institute of Public Health. She participated in manpower training of part-time enumerator sponsored by Department of Social Security, Women and Child Development, Punjab. Dr. Manishi completed foundation course in palliative medicine and certificate course in essentials of palliative care in 2019. Currently, she is an editorial board member of International Journal of Public Health and Epidemiology Research and Journal of Family Medicine and Healthcare. Also, reviewer of current Journal of Applied Science and Technology. Welcome you, ma'am. Then I would like to welcome Dr. Kiran Bala ma'am, MBBS MD, Associate Professor in the Department of Community Medicine, GMC Jammu. She is having 11 years of academic and research experience. She has worked as one of the co-investigators in conducting clinical trials of proto-vaccines and pneumococcal conjugate vaccines. Her academic interests include research in the areas of NCDs, maternal and child health, pediatric, infectious diseases, etc. She has done post-PG courses in epidemiology, research methodology, and MCCD. She is actively involved in analyzing course of mortality data in India under the Minerva network. She has also authored one chapter in PGD MPS program offered by IGNOR and has regular publications in various index journals of national and international repute. Welcome you, ma'am. I would like to warmly welcome Dr. Akshat Pathak, MBBS MD, Assistant Professor, Community Medicine, GR Medical College, Gwalior. Life member, Indian Medical Association, Indian Association of Preventive and Safety Medicine, Indian Public Health Association, and Epidemiology Foundation of India. Received Times of India Icons of Health 2019 Award. Publications in various international and national index journals. Field of interest epidemiology of communicable and non-communicable diseases, nutrition in children, awareness among marginalized populations about public health programs, etc. A warm welcome you all to this oral session 8 on national communicable diseases. And I would also like to welcome our presenting author. We are having 6 presenting authors here, and our chairperson, please note their registration number. So with all your permission, let me begin our session. So first presentation will be by Dr. Sonam ma'am, registration number 218, on the title Effects of Oral Contraceptive Use on Blood Pressure and Body Mass Index among females of Uttarakhand. I kindly welcome you, ma'am. Hello, ma'am. Manisha, ma'am. Yes, ma'am. Are you audible? Yes, ma'am. Please proceed, ma'am. Can you please share your PPT? Hello, Dr. Sonama.
I'm audible.
Yes, ma'am. You're perfectly audible. Can you please share the screen?
Okay.
So in this presentation, we are giving 5 minutes for your presentation, and after that, there will be a questions and answer session, and it will be for 1 minute.
Hello.
Yes, ma'am. It is visible, ma'am. Please proceed, ma'am.
Okay, thank you so much. Very good morning to everyone. I, Dr. Sona Maheshwari, is going to present the topic effects of oral contraceptive use on blood pressure and body mass index among females of Uttarakhand. Oral contraceptives are an important and widely accepted contraceptive modality used throughout the world. Weight gain is often considered as a side effect of combined hormonal contraceptives, and many clinicians believe that an association exists between them. Many epidemiological studies have directed that intake to oral contraception may result to cause variation in systolic blood pressure, diastolic blood pressures, and prevalence of hypertension in various study designs. However, a causal relationship between combination contraceptive and weight gain has not been established. Studies in normotensive women have shown an increase in blood pressure associated with oral contraceptive use. Although less information was available about the effect of commonly used oral contraceptives containing both estrogen and progesterone on blood pressure or the prevalence of hypertension in Uttarakhand women. This study aims to examine the socioeconomic correlates of body mass index, blood pressure, and contraceptive use by reproductive age group women of Uttarakhand. For this study, we used National Family Health Survey data, which was conducted during 2015 and 16, and the total sample size was 17,300 women of Uttarakhand. Due to missing and non-response information for different variables, sample size has variation at the time of analysis. In this study, we categorize hypertension according to JNC8 and body mass index according to WHO. For analysis, we divide all female subjects into 6 age groups, and for inter-age group comparison, we use ANOVA, and for post-hoc, we use Bonify multiple comparison test. Also, to find the relationship between of BMI or systolic diastolic blood pressure with contraceptive use and socio-demographic variables are examined with the help of ANOVA. Analysis is done using SPSS version 24, and here E value is less than 0.05 is considered as a significance level throughout the study. These are the results for our study. The first table describes about the in this the table describes the all social demographic characteristics of the subjects divided into six age group. The mean age at minarchy was lowest in the age group 15 to 19. The variation in mean age at minarchy was found to be significant using ANOVA. The number of live births over the women total lifetime were lower in younger age groups and also found to be significant. Mean years of education were longest in the age group 15 to 19 than in other age groups. The table 2 presents the prevalence of obesity for the subject for the females. According to this table, significant intergroup differences were found. The BMI had consistent increment according to age. The proportion of pre-obese and obese categories was highest in the 40 plus age group, accounting for 32.3%, followed by 35 and 30 to 34 age group. Table 3 presents the mean blood pressure and prevalence of hypertension. According to this, significant intergroup differences were seen for both types of blood pressures. Systolic and diastolic blood pressure was highest in the age group 40 plus than for the other age groups and also found to be significant. The prevalence of pre-hypertension, hypertension grade 1 and hypertension grade 2 was highest among the 40 plus age group with the respective proportion as 54%, 19.6% and 5.5%. This table presents the mean BMI and diastolic blood pressure and systolic blood pressure according by socio-demographic variables. According to this table, systolic blood pressure and diastolic blood pressure differed significantly with the number of live births, highest year of education, and age at menarche. In this table, we also applied ANOVA, and for post-hack, we also applied Bonnet-Freire multiple comparison test. These are the about discussion and conclusion. In the present nationwide cross-sectional study among female of reproductive age group, the use of oral contraceptive was positively associated with systolic blood pressure, diastolic blood pressure levels, and BMI. It has been observed that with increase in age, a dramatic increase in overweight and obesity is observed. The present study has several demerits as well. On data part, lack of information is there regarding the use of duration of contraceptive use, and therefore association is considered only as a study of cross-sectional design could not be used to determine causation. Thank you.
Thank you so much, Dr. Sonam. Registration number was 218. So now is the time for a Q&A session. I kindly welcome our chairperson for having inquiry to Dr.
Sorry,
Sonam.
sorry, your voice is not clear, ma'am.
Yes, ma'am.
Sorry, your voice is not clear.
Sorry, ma'am. I kindly request our chairperson for having a Q&A session. If you are having any query, you can ask to Dr. Sonam now.
Yes, thank you, Dr. Akshita. Is my voice audible now? And Dr.
Yes,
Sonam?
ma'am. Audible.
Good presentation, Dr. Sonam.
Ma'am, your voice is very low.
Yes, Dr. Sonam. Am I audible now?
Ma'am, you are audible, but your voice is very low.
Okay. Should I put my question in the chat box then?
Yeah, sure, ma'am.
Okay. So I just wanted to ask when was the study done? You didn't mention the time period.
Oh, ma'am, it was conducted during 2015 and 16 National Family Health Survey round 4th.
Okay. And what do you think are the further implications of this study?
Ma'am, we can take the duration of use of contraceptive use
Hmm.
uh,
The
and
duration was not taken in your study, na?
no, ma'am, this kind of data is not available in NFHS 4.
Okay. So what do you think should be further implications then?
Ma'am, I think that we are conducted on a small, we are conducting a small study, taking
Mhm.
the use of contraceptive as a main factor,
Okay.
taking the duration of contraceptive use.
Okay. So you want to further do this, right?
Yes, yes, ma'am.
Mm. Now I request other members, other co-chairpersons to kindly ask if they have any comments.
If there is any comments, can we proceed to the next presentation now?
Yes, Dr. Akshat and Dr. Kiran, if they have any comments, otherwise you can proceed to the further next.
Good morning, ma'am. I'm Dr. Kiran. Uh, no comments from my side. You can call second presenter. Hello.
Dr. Akshay sir?
Actually, there is a network issue. Your voice is cracking, so could not comment on the study. But you can call the second presenter from my side. No issue.
Okay, you can call the next presenter.
Okay, sir, thank you, sir. So,
Thank you
next
so much.
presenter,
Thank you so much.
I would, I would kindly welcome Dr. Jyotish ma'am, registration number 212, on the topic prevalence and predictive factors associated with alcohol use in school-going adolescents. I kindly request Dr. Jyotish ma'am for sharing his screen. Dr. Jyotish, are you there? Yes, your PPTs are visible. Kindly proceed. Can you please unmute your audio?
Good morning, everyone. Ma'am, am I audible now?
Yes, ma'am, you are audible. Please proceed, ma'am.
So, good morning, everyone. I'm Dr. Durgesh from Medical College, New York, Himachal. And my study is prevalence to find out the prevalence and predicting factors of alcohol use in school going adolescents in Himachal. So, as we know, habits adopted during adolescence are likely to be continued throughout life. So, if an adolescent develops the habit of taking alcohol, then it is most likely to be continued throughout their life. Many alcohol users become addicted to it. Alcohol reduces control, and hence there is increased vulnerability to other risky behavior like domestic violence, drunk driving, and many others. Even drunk driving can lead to accident and even death. And there are many social factors in our environment, in the family, in the society, in school, which have very important role in determining the behavior adopted by the adolescent. So aim of my study was to assess the prevalence of alcohol use in the school-going adolescent and to investigate the associated individual and social risk and protective factors, as we call them social determinants. So methodology, a cross-sectional study was conducted among the 720 school-going adolescent of the 10 randomly selected schools of the study area, and stratified random sampling was used to select the participants, and self-administered pre-validated modified gaps questionnaire was used to collect the data, and adolescents were informed about the anonymity of the data, and data was collected in the examination setting. The result data was analyzed using EpiInfo software for Windows, and the prevalence of alcohol use was found to be 6.1%, and which was 10% in males and 1.3% in females. And the binary logistic regression model revealed that parents and peers' alcohol using behavior significantly predict the alcohol use by the adolescent. And talking and discussing issue with the family and good relation with the teachers protect the adolescent from the alcohol use. This was the result of the logistic regression. Male gender was found to be a risk factor for alcohol use, having odds ratio 4. And discussing problem with family, having good relation with family members was found to be protective factor, and having odds ratio 0.3. And family member using alcohol was found to be a risk factor, having odds ratio 3.6. And good relation with teacher was found to be a protective factor, having odds ratio 0.4. So conclusion, the alcohol use is a common experience among school-going adolescents. Alcohol use is influenced by the family members, peers, and school teachers. The role of parents and teachers in fighting this negative habit is very important. There is a need of an intervention involving schools, peers, and all the family members. So the adolescent health program should include intervention at all these levels. Parents who use alcohol should quit this habit. This will not only restore their own health, it will also protect their children from the alcohol use. All parents and teachers should be counseled to talk to the children and discuss their problems. And adolescents should be educated of the ill effects of the alcohol use, and there should be life skill should be taught in the school so that adolescents develop a strong willpower, hence are not influenced by the peer pressure. That's all. Thank you.
Thank you so much, Dr. Jyotish ma'am. Registration number was 212. So
No,
I
no, ma'am.
kindly
No, ma'am. My registration number is 205.
205.
Yes.
Okay, ma'am. Now I would kindly request our chairpersons for asking inquiries.
Hello, am I audible?
Yes, ma'am.
Good morning, Durgesh.
Good morning, ma'am.
Just wanted to know, this is a very sensitive topic to have information about alcohol or smoking, and that too from the adolescent group. So I just want
Yes.
to know what was your response rate, and how did you collected the data actually? Did you take help of teachers or the principal, or how, you just, it's a cross-sectional study, you just visited them, and did they easily provide you information about the use of alcohol?
Yeah. Ma'am, I took the permission from the Directorate of Education. I took the permission letter from them. Then I visited the school. Then I gave a talk to the students every class. And then the response rate was very good. Out of
How much
720,
it was?
out of 720 children, 704 responded. So
Okay, and adolescent is from 10 to 19 years, I suppose. So which group basically you targeted?
I targeted 14 to 15, and then 15. This was my group, 14 to 15, then 16 to 17, 18 to 19.
Okay, okay. Thank you. Thank you.
Thank you so much, ma'am.
Thank you. Ma'am, please notice my registration number is 205.
Thank you so much, ma'am. Any other inquiries have been kindly welcome other chairpersons for asking any inquiries they are having.
Mhm. No, Dr. Akshara, you can proceed to the next participant from my side.
Okay, ma'am. Thank you, ma'am. So, our next presenter is Dr. Vijayananda Naik, and on the title, Does Hypertension Deteriorate the Health-Related Quality of Life? A matched cross-sectional study. So, I would kindly welcome Dr. Vijayananda Naik sir for proceeding. Dr. Durgesh ma'am, kindly request you to stop sharing the screen. Thank you, ma'am.
Okay, good morning to all. Can you see? Can you hear me? Am I audible?
Yes, sir. Yes, sir.
Okay.
Yes, sir. Sir, can
Okay.
you please say your registration number, please?
I think 162.
Okay, sir. Thank you, sir. 162.
Okay. Once again, good morning to judges and all the presenters present here. I am Dr. Vishayananda Naik from AIMS Patna, and I will be presenting our study. Does hypertension deteriorates the health-related quality of life? A matched cross-sectional analytical study in an urban area of Puducherry, South India. Hypertension is a chronic morbidity and needs lifelong management. Like in other chronic diseases, lifestyle modification and daily medication is required on the case-to-case basis. Physical and mental health signs and symptoms plus lifelong health management leads to poor quality of life among hypertensive. But literature on health-related quality of life among hypertensive is limited in India, and to the best of our knowledge, there is no such studies from Pondicherry. So, in this background, we planned this study with the objective to compare the health-related quality of life of hypertensive and age gender matched non-hypertensive individual in an urban area of Puducherry. It was a cross-sectional study done over a period of 2 months in 2016 in the urban field practice area of Jipmer, Pondicherry, and there were two groups. The study group included the hypertensives who were chosen consecutively in the NCD clinic of USTC, and the comparison group were non-hypertensive. They were gender and age matched, which is plus minus 5 years from the community. We used one pre-tested study tool. We said two parts. First part includes socio-demographic details of the participants, cases and study group and comparison group. It had general information and hypertension details. The second part had Tamil language validated SF12, that is short form 12 questionnaire. That had 12 items in 8 domains. 4 items were negatively worded. Statistical analysis, all the negatively worded items were reversed, and each for each domain, the score was transformed to 0 to 100 scale. And the health-related quality of life was further classified into 3 levels: high, medium, and low. And we use unpaired and chi-square test for statistical analysis using SPSS 20. This is the table showing the sociodemographic characteristic of study population. As you can see, age and gender, they are comparable in both the groups. Education also comparable in both the groups. In both the group, majority of the participants were in lower socioeconomic status, and it is more so in non-hypertensive group. Majority of the participants in either group were from nuclear family, currently married, and um, about a quarter of participants in either the group were using alcohol and using tobacco products, and about 10%, 10 to 13% were using tobacco products. This table shows the difference in health-related quality of life between the two groups. As you can see, there is no statistically significant difference in health-related quality of life in mental health component, but in physical health component, there was statistically significant difference, and health-related quality of life was worse in hypertensive group. This figure also shows the health-related quality of life level between the based on the level between the hypertensive and non-hypertensive individuals, and it was found to be statistically significant. And higher proportion of hypertensive were having low quality of life. So, consistent to our studies, other studies also sorry, consistent to other studies, our study also found that poor quality of poor health related quality of life among hypertensive than non-hypertensive, and it was more pronounced or statistically significant in physical domain. Strength of our study, it was a matched comparative cross-sectional study, which was gender and age matched, and we used one validated questionnaire. Limitation, it cannot be generalized to other parts of India, and sample size was limited, and feasibility sampling was adapted for recruiting the hypertensive individuals. So from our study, we concluded that health-related quality of life was poor among hypertensive and more so in physical domains. So based on this, we recommended that the hypertensive forms a vulnerable population, since hypertensive forms a vulnerable population, and they merit focused attention by the healthcare provider with respect to disease and management to improve the health-related quality of life. These are the references. Thank you.
Thank you so much, sir, for your presentation. And now I will kindly request our chairperson for putting forward the inquiries.
Yes, Dr. Vijaya,
Yes, madam.
nice presentation.
Thank you, madam.
I just wanted to ask, how did you validate your questionnaire?
Actually, madam, that SF12 questionnaire, we used language and face validation, madam. So SF12 questionnaire is openly available, freely available. So we translated that one into English, and in our RSTC area, we asked the same question, and any modification that was noted in Tamil, again, that was back translated to English, and it was shown to expert in the field of NCD. And we, after their expert, again, we pre-tested in the sample of population. Again, that was translated to Tamil. We tested in the sample of population. Based on their response, we modified and back translated to English. And all the questions were applied applied in Tamil language only.
Okay. And how do you define this health-related quality of life in your study?
Actually, any definition we have not used. We only, from the questionnaire, that tool only. Based on the tool, we have defined low, high, or medium. Like I'll show you, based on the score given, health-related quality of life, whether it is high, if the score is more than 60, medium, the score is between 40 to 60, and low if it is less than 60, because health-related quality of life is a very subjective. So based on the questionnaire, we have given score, and that score we have again categorized.
Okay. Thank you so much. Thank you.
Thank you, madam.
Good morning, sir.
Good morning, madam.
I just want to know that according to your experience with the study, what
Yes,
should
madam.
be what should be done to improve this quality of life in field level?
Actually, madam, over the period of time, the mental component, they get adjusted to the disease. And with regard to physical component, we need to to motivate them for regular follow-up. And further, we can identify whether it is because of hypertension or there may be other causes that we need to find. And one more thing, any focus group discussion that may help.
Yes, yes. Thank you. Thank you, sir.
Thank you, madam.
Thank you so much, ma'am. Thank you so much, Dr. Vishya sir.
Thank you.
So now we will go to the next presentation. Sir, can you please stop sharing the screen?
Yes.
So now I kindly request Dr. Rehan C. Mohammed for presenting on the topic validity and concordance of self-reported diabetes in proportion and determinants of hidden diabetes. Kindly welcome you, ma'am.
Thank you, Dr. Akshara. Uh, Good morning, everyone. Can I share the screen? It seems that the screen is, or Dr. Bijayananda's screen is being seen.
Yes, ma'am. Your screen is visible.
No, this is
Can you,
not my screen. The one that is visible is Dr. Bijayananda's screen. So can you ask him to stop screen sharing?
okay, okay. Dr. Vijay, sir, can you please stop sharing the screen?
Yes, I am doing that one.
Dr. Vijay, sir, can you please stop sharing the screen?
Yeah, that's what I'm doing. I'm not able to do somewhere. I'll leave this one. That will be better.
Then once you can leave and please
Yeah,
rejoin.
can you please remove me from the group again? I'll join. That will be better.
Okay, sir.
Please remove me. I'll again join.
Yes, ma'am.
Is my screen visible?
Yes, ma'am. Screen is visible.
Okay.
Ma'am, can you please say your registration number?
Actually, in the group, it is given as 162, but my registration as per the document given is 162. I mean, then 161.
Okay, ma'am. So your registration number is 161.
Yeah.
Okay, ma'am. Please proceed, ma'am.
So, good morning, everyone. I'm Dr. Rehna C. Mohammed, MPH scholar, Amrita Institute of Medical Sciences, Cochin. So, the title of my paper is Validity and Concordance of Self-Reported Diabetes and Proportion and Determinants of Hidden Diabetes in the Rural Population, Kerala. As you'll know, diabetes is one of the largest public health concerns, and this is the global burden of 2017 and the projection for 2025, as it's shown in the table. Diabetes is often defined by using self-reported diagnosis in epidemiologic studies. Hence, accuracy of self-report play a very vital role in public health research. Hence, the objectives of my study were to assess the validity and concordance of self-reported prevalence of diabetes using multiple reference definition, to assess variation in validity and agreement of self-reported diabetes with gender, socioeconomic status, and age subgroups, to estimate the proportion of hidden diabetes and to determine factors associated with it. So the data for the study was obtained from a community-based study, Indira, which was conducted in 75 wards of adjoining panchayats in Ernakulam district, Kerala. Questionnaire-based survey by ASHA workers after proper training and orientation session being given to them. From the Indira data set, in the second stage, first stage, it was a questionnaire stage. In the second stage, the people whose FBS were checked was included, which has been a population of 7,559. Then validity and concordance of the self-report were assessed with the reference definition using SPSS standard version 21. And the reference definition was taken as fasting blood sugar greater than or equal to 126 milligram per deciliter, medication for diabetes, dietary modification, physical activity, if any. So this is a map of the area where the study was conducted. Coming to the result, so this is a table which shows a socio-demographic profile of the participants with age, gender, socioeconomic status, and religion. The prevalence of self-reported diabetes was found to be 14.5, whereas the diabetes as per standard reference definition came to be 18.2. So this is a 2x2 table which depicts self-reported diabetes as against diabetes as per the standard reference definition. So in this, you can see that the total of 5,559 people, 541 who reported as not having diabetes had diabetes as per reference definition, and a group of 261 individuals had wrongly reported as having diabetes. So our discordant percentage came to be 10.7% and the concordant as 89.3. This is a statistic which shows the overall value, while the sensitivity was 60.71, specificity was 95.78, positive and negative likelihood ratio 14.38 and 0.41 respectively. Disease prevalence, as earlier said, was 18.22, positive and negative predictive value 76.21, 91.60 respectively, and the accuracy was 89.39%. So this table, it shows a distribution of sensitivity, specificity, and the kappa value in each group. So you can see that in a lower sensitivity and agreement has been found in the age group of 30 to 39. So it's a very low sensitivity which has been found in that age group. And in gender, you can see among the females and the socio-economic strata and the above poverty level has been noted. Now coming to the hidden diabetes part. So as we said, the false negative value 541, it accounted for 7.1% of hidden diabetes in the population. So when the social demographic variable has been found, with that we could find that the age group, it was found significant. So this is the percentages as per the percentages within this the percentage of hidden diabetes in the diabetes gold standard, and this is as per the total group. So this is how the percentages have come in each of it, which age group was found to be significant. Coming to the discussion, validity and concordance assessment of self-reported diabetes globally gave a range from 34 to 83 and specificity 90 to 98, but in our study, it was 39.2 to 68 and specificity 93 to 98.8. Hidden diabetes of 60.7% among diabetic in 30 to 39 age group calls for importance of frequent screening and importance of studies like Indira. There had been a small proportion of 3.4, a false positive group, which also needs a confrontation of the policy implementation. Coming to the conclusion, an exercise of caution is indicated while interpreting the results. Community studies using self-reported data calls for further studies to elaborate the predictors of sensitivity and their strength of association, importance of health intervention programs, and necessity of improving public knowledge and information needs to be highlighted. So these are my references. Thank you.
Thank you so much, Dr. Romana. I would kindly request our chairperson who have joined this session, Dr. Rehana ma'am.
Yes, very good presentation, Dr. Anna.
Thank you so much, ma'am.
I just wanted to ask, is there any limitation that you are recognizing in your study regarding this hypertension?
Actually, this was a the Ashas were trained to get the uh, interview. So Ashas were trained, and it was the secondary data from them that I've collected and analyzed. So that might be a limitation because it was not a face-to-face interview. And coming to other parts, the study was the first phase of getting the details of the self reports was actually done from 2017 to 18, and the second stage of physical examination, it was during from 2018 to 19. So that might actually, maybe in between that period, if they have developed the diabetes, that may be a limitation again. So
Okay, okay. Thank you.
thank you,
That's
ma'am.
all from my side.
Thank you, ma'am.
Good morning, Dr. Rehana.
Good morning, ma'am.
Very nice presentation.
Thank you, ma'am.
I just want to know that for the self reporting, you how did you how do the people how do you actually label them as self-reporting, by symptoms or by any blood test?
No, it is just a self-report, ma'am. The
Yeah,
Ashas
how?
asking them whether you are having diabetes. So
Okay, okay.
if they say yes, then they are
Then
reported as yes, and if
yes,
no,
okay, okay, okay. So no symptoms or no blood test were seen, just by their commitment you label them as self-reported.
So the study actually was to know how far we can rely on the self-reports the people give.
Okay,
So generally, the epidemiologic studies, we only look when we are looking for the self-report, how far are we within in getting the validated reports.
okay, thank you, thank you.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you, Dr. Akshara. Thank you, everyone.
Next presentation, I would kindly welcome Dr. Prabjit Kaur, presenting on the title, The Study of Stressors of Caregiving and Associated Factors Among Caregivers of Cardiovascular Diseases. Please proceed,
Yeah.
ma'am.
Good morning, ma'am. Am I audible?
Yes, ma'am. Can you please say your registration number?
It's 388.
Okay, ma'am. Thank you, ma'am.
Good morning. Okay, I'll start. Good morning, everyone. I'm Dr. Prabjit, third year post graduate from Lady Harding Medical College, New Delhi, and I'll be presenting my oral presentation on the topic Study of Stresses of Caregiving and Associated Factors Among Caregivers of Cardiovascular Disease. The objectives are to assess the magnitude of these stresses of caregiving among the caregivers of cardiovascular diseases and to study the various factors influencing the same. So the changing demographic landscape of the contemporary societies with the advanced medical technology and the transition from communicable diseases to non-communicable diseases over the last 2 decades, the burden of chronic illnesses has been increasing, as reported by the World Health Organization, that the NCDs contribute to about 71% of the mortality and morbidity, with cardiovascular being the leading in that with about 31% of it. So since the burden of these chronic illnesses, most of them are being managed at home, and the taking care of these patients falls primarily on their family members. So providing care over a longer period of time adds to the stresses. So stresses are defined as the conditions, experiences, and activities that are problematic to the people, that is, they threaten them toward their efforts and defeat their dreams. So stresses can be categorized as primary and secondary. Primary are the ones which are originating just directly because of the patient's condition, like his changed behavior, and the secondary, which are the outcomes of caregiving. That is, which may be because of the family conflict, job conflict, economic burden. I'll be discussing them in further slide. So they tend to impact the health of the caregivers. So because of the increased stress and burden. Though it's a community-based cross-sectional study which was carried out in Delhi in 2019 in a sample size of 384. Systematic random sampling was done, and the study unit was the primary caregiver for the cardiovascular disease. Data was collected using self-designed pre-tested semi-structured questionnaire, and the data was analyzed using SPSS version 25, and chi-square test was used to test the association with the p-value of a cutoff being taken 0.005. It was found that in around 90% of the caregivers, they had one or the other form of the stressor, with primary stressors being found in 82.6% of those caregivers and secondary stressors in 79.4%. So here are the various primary stressors which were assessed. It was found in that around two-thirds of the caregivers, knowing the medical condition and the changed patient behavior due to the ailment uh, contributed the most as the reasons for stressors. Similarly, one-third of them had the stressor due to additional workload and patient dependency on caregiver, with around 10% having the stressor to take care of the patients in their daily activities of living. Talking about the secondary stressors, it was found that the leading cause of the stressor was economic burden, which was found in around 70% of the caregivers, with one-third of them having disturbed mental well-being due to taking care of the patient and family conflict, and 20% of them had job conflict or problems at the job for taking care of the patient. When assessing the factors regarding the stresses, it was found that the age, gender, and relationship to the patient did not have any significant association as per the study in relation to the stressors. And it was found that the duration of caregiving, as the duration of the caregiving was increasing, the presence of stresses, the proportion of stresses was also found to have increased, was found to have a statistically significant association with the duration of caregiving. Uh, Studying about the stresses among caregivers in relation to the type of the cardiovascular disease, it was found that in hypertension, it was just around 87.8% had the stressors, whereas in all the rest all had the stressors. And this was also found to have a statistically significant p-value of 0.002. This further when the stresses were studied in relation to the regularity of the treatment, that the patients who were not regular had a significantly higher proportion of stresses as compared to those who were on regular treatment. Similarly, in relation to the clinical condition of the patient, those who were under control had a lesser amount of stresses in comparison to those who were not under control. Talking about the recommendations in the conclusion, so the study highlights the social, economic, and psychological risk of stresses, which are nearly universal among all the primary caregivers. So the major factors associated with stresses were found to be prolonged duration of caregiving, the type of cardiovascular diseases being studied, the regularity of treatment and the control, and the clinical condition of the patient. So patient and caregiver, they form a dyad where caregivers also becomes a high-risk group that needs to be taken care of, and interventions may aim to form informal support groups for caregivers so that it improves the quality of the caregiving. And positive coping strategies can be reinforced depending upon the stressors. Thank you.
Thank you so much, Dr. Prajit ma'am. I will kindly request our chairpersons for a Q&A session with Dr. Prajit ma'am.
Yes, good presentation, Dr. Prabjeet.
Good morning.
Good morning, good morning. Very good presentation. Just had one
Hello.
question that how did you calculated the sample size for your study?
Ma'am, you are not audible.
Yes, Dr. Prabjeet, am I audible now? Yes, Dr. Prabjeet.
Dr. Prajit ma'am, are you audible?
Dr. Prabjeet, I think she is not audible. Her connection is lost.
Dr. Prabjeet Kaur, are you there? So can we move for the next presentation?
Yes, Dr. Akshara, we can proceed next.
Yes, ma'am. Thank you, ma'am. So I would like to welcome Dr. Gaurika Saxena for presenting on the topic Cancer in the Eclipse of COVID-19, a doctor's perception.
Thank you, Ms. Akshara. I hope my screen is visible to everybody.
Yes, ma'am. It's visible. You can proceed, ma'am.
Yeah. Good morning, one and all. My research is Cancer in the Eclipse of COVID-19, a doctor's perception. As we all know that a rapid expanding COVID virus is a respiratory pandemic disorder that is completing the whole world. And since the day COVID-19 has been infected, the world is going through the frontline warriors, and there are two battles at every front that is going on. That is cancer care and COVID-19. Doctors who are providing cancer care in the eclipse of COVID-19 are exposed to all sort of crises, including stress, anxiety, and depression, also psychological crisis. And most of them are also undergoing high blood pressure, other fatigue, and other stress related disorders. So the main aim of my study was to explore the perception of doctors dealing with cancer care and treatment during this. The primary objective of the study was to explore the experience of doctors in cancer care and treatment during COVID-19. The secondary objectives were to understand the perception of doctors about how their experiences, both negative and positive, have affected their lives both personally and professionally, to recommend the preparedness and to also prepare the future doctors for the betterment of both clinics and patients in similar scenarios. So the material and methods that was used, it was a qualitative study done at AIMS Rishikesh, Uttarakhand, and the study participants were the consultant and SRs from the Department of Radiation Oncology, Gyno-oncology, Uro-oncology, Neurology, Surgical Oncology, and Hemat-oncology. The study duration was 2 months. The sample size was, it was a purposeful sampling. Data collection was done up to the point when we get the data saturation done. So the data collection tool was data was collected through in-depth interviews of about 40 to 50 minutes using semi-structured interview schedules by trained interviews, and all the interviews were auto-taped. The study setting was AIMS Rishikesh. The study was conducted in the OPD and IPD of radiation oncology, gyno-oncology, uro-oncology, neurology, surgical oncology, and hemat-oncology. The data analysis was done using conventional content analysis approach and is done by two independent investigators. So the result that we came can be divided in summarized into four themes. That is, the first one was negative emotions present in early stage, consisting of fatigue, discomfort, and helplessness, was caused by high intensity of work, fear, and anxiety, and concern for patients and family members. Second stage come up with self-coping styles included psychological and self-adjustment, Ulster acts, team support, and rational cognition. The third stage that turned out, we found growth under pressure, which included increased affection and gratefulness, development of professional responsibility, and self-reflection. And the last, the final stage that turned out, showed that positive emotions. So come up to the last discussion and conclusion, we found during this pandemic outbreak, positive and negative emotions of the doctors in cancer care intervened and coexisted. In the early stage, negative emotions were dominant and positive. In the later stage, positive and negative emotions
emotions appeared gradually. Self-coping styles and psychological growth played an important role in maintaining mental health of all the doctors in cancer at the time of COVID-19. The study has given us some important insights into how these doctors were managing during the spring peak of COVID-19 and the treatment of their cancer patients. As we see rates of infection rise again around the world, it's crucial that we learn lessons to protect oncological staff and cancer patients and ensure patients getting the best treatment now in the coming months. As I would like to conclude by a quote said by one of my participants is, we healers deserve to be healed. Thank you. That was me, Dr. Goreka. And these are the references. Hello.
Yes, ma'am. Thank you, ma'am. Now, I would kindly request our chairperson for having a Q&A session with Dr. Gauriva Saxena.
Yes, Dr. Gorika. Can you hear me, Dr.
Yes, ma'am. Good
Gorika?
morning, ma'am.
Good morning. Good morning.
Yes, ma'am. Yes, ma'am.
Very good presentation. Just wanted to ask
Thank you so much, ma'am.
whether you used any software for analyzing your qualitative data?
Ma'am, it was all self-perception taken by two different interviewed the auto tapes, listened them very clearly, and made a report out of every interview, and then a combined report was made for every interview, and then the conclusions were traced out.
Okay. So you didn't use any software for analyzing this?
No, ma'am. No, ma'am. No, ma'am.
Okay, okay. And you recognize the themes out of it?
Yes, ma'am.
Okay, okay. Did you recognize
Yes,
any
ma'am.
items or did coding was also done for your themes?
Ma'am, can you repeat the question? I'm sorry, your voice
You,
break off.
you
Very sorry.
recognize the themes and after that further coding or items they were recognized or not?
Yes, ma'am.
Okay, okay. Thank you so much from my side.
Dr. Gorika, can you give me your registration number once again?
So it's 1414.
Okay, thank you.
Thank you.
Excuse me, this is Dr. Prabjeet. My network had got disrupted, ma'am. I think you were asking a question.
Okay.
Yes, ma'am.
Yeah.
Okay, Dr. Prabjeet, I was just asking you, how did you calculated the sample size for your study?
Yes, ma'am. I had taken there was one study done in Kolkata in 2010 where they had assessed the stresses in the patients, in caregivers for stroke by Dr. K. Das. So, ma'am, there the value of the stresses they had found 40 to 80%. So, taking that 40% as the prevalence of stresses among cardiovascular, because overall I could not find an article for all the cardiovascular. So, I had taken for the stroke patients. Caregivers from there and taking the allowable error of 25%, and then ma'am I had calculated using OPQ by L square, and I had gotten 384 sample size, ma'am.
Okay, thank you so much. Thank you.
Yeah, thank you, ma'am.
Thank you, ma'am. I would like to inform our chairperson that two of our presenters, that is Dr. Dija Chandrasekhar Kumar Pandya and Dr. E. Shantanu Kumar Chadha, are not able to present because of some personal reasons. So, with this, our presentation got over. So, I would kindly welcome our chairperson, Dr. Manisha Nagpal, ma'am, for enlightening us with your kind words on this oral session 8 on the topic non-communicable diseases. Please welcome, ma'am. Ma'am, can you please unmute your audio?
Yes, yes. Yes, can you hear me,
Thank you,
Dr.
ma'am.
Aksha?
Yes, ma'am.
Okay, okay. So thank you so much and for giving me this opportunity. And this was a very nice session. It was very good effort by all the presenters, and I highly admire their efforts and for the smooth going of the session. Thank you very much.
So now, I would like to welcome Dr. Kiran Bala ma'am, Associate Professor, for enlightening us with your kind words, ma'am.
Good morning, everyone.
Good morning,
Hello.
ma'am.
Okay. It's actually a very, very, very nice experience, and it's good to see you, Dr. Manisha. I
Same
have
here,
just,
Dr. Kiran. Same
I have
here.
just read your name number of times, but it's a pleasure to see you. And I just want to thank all the coordinators, and they have such a beautiful coordination, and the session was very good, very learning, and it's nice experience. Thank you.
Thank you, ma'am. Thank you so much. Next, I would kindly welcome Dr. Akshit Patil, sir, Assistant Professor, for enlightening us with your kind words, sir. Dr. Akshit Patil, sir, can you hear us? So with this, we finished our oral session 8. Thank you so much. Thank you so much, everyone. I hope you all enjoyed this amazing presentation.
Thank you, Ms. Akshara.
Thank you,
Thank you,
Dr.
ma'am.
Akshara. Thank you.
Thank you,
Thank
Akshara.
you, ma'am.
Aradhika, for Good morning, everyone. Good morning to respected chairperson, eminent speakers, and dear delegates. A very warm welcome to all of you from the team Eficon 2020. Now we start with our poster session, primary health care. We have eminent personalities as chairperson here. Dr. Akshay Minhas, MD Community Medicine, Dr. Shiv Kumar Yadav, Dr. Shiv Kumar Yadav, Assistant Professor Community Medicine, Government Doon Medical College, Dehradun, and Dr. Priyanka Keswani, Associate Professor, Autonomous State Medical College, Basti. Now I'll request our presenter to start the session. Our first presenter is Dr. Major Singh. Can you hear me?
Yes, ma'am. I can hear you, ma'am. I'm starting the session, ma'am.
Yeah, please start sharing the screen.
Hello.
Hello. Please start sharing the screen.
Ma'am, I have shared my screen. Ma'am. Can you see that?
Not visible, sir.
Ma'am, I shared the screen, ma'am.
Screen is not visible. If you are not able, so I can share.
Yes, ma'am. You can share, ma'am.
Okay. Yes, please start.
Good morning to all of you, respected chairpersons, esteemed doctors, and my fellow dear doctors in making. Myself, Major Singh, batch 2016 from NC Medical College and Hospital, Panipat, Islam. Today I will present my e-poster on special immunization drive of migrant population in slum area of district Panipat, Haryana. As you know, immunity derives either from infection or vaccination, and prevention is always better than cure. Hence, immunization has been cited as one of the biggest medical breakthroughs in human history. Various research studies have proved that vaccination are most effective medical intervention in reducing morbidity, disability, and mortality from infectious diseases, thereby suppressing mortal contribution of antibiotics. Despite overall improvement in immunization coverage under NHM, some outbreaks have been reported in like measles and diphtheria, especially in high-risk areas in our state, where the beneficiaries were residing in slums or migrant from one place to another. Such type of areas need proper survey and the vision for improving immunization in industrial slums. Now, what's the objective? To assess the impact of special immunization drive in high-risk areas. A methodology, study area. The, the laborer working in unorganized sector have their children residing in temporary built huts, nearby factories or project sites where construction work of building under process. I have taken 515 beneficiaries, which includes pregnant women, adolescents, and children below 5 years were immunized. The study period is on 12 September 2019. The health team comprises health inspector, ANMs, ASHA workers, so at the area of migrant workers, and a list of beneficiaries was prepared under supervision of medical officer of concerned PSC with joint collaboration of NC Medical College and Hospital Israna. Vaccine logistics were produced and staffs were deployed from PSC Nolta and NC Medical College and Hospital in premise of the medical college. I sharing my results. As you can see, the vaccination includes BCG, where the first dose was given to the 4 children, which are below the age of 5 years. OPV, first dose was given to the 5 children less than 5 years. Penta, first dose was given to the 8 children. FIPV, first dose was given to the 4 children. PCV, first dose was given to the 4 children. MR, first dose was given to the 4 children. JE, first dose was given to the 4 children. And Rota, first dose was given to the 4 children. As you know, TD, first dose was given to one of the adolescent and 2 pregnant women. Also, the iron and folic acid tablets are also distributed to the one of the adolescents. And vitamin A is also given to the 4 children, which are below the 5 years. There is no major AFI reported on follow-up visits. Two of the children were detected on follow-up with the complaints of local tenderness and one of children with the complaint of local tenderness at the injection site, and one of they get fever at the follow-up. Now, what is the conclusion and recommendation? District Health Department and stakeholder participating in special immunization drive are valuable. Such type of special immunization drive may be carried out in the slum areas to protect the vulnerable population, especially in high-risk area, to cover the left-out of children. Awareness activities was also carried out regarding immunization against vaccine-preventable diseases. Thank you.
Thank you, Dr. Major Singh. Sir, any question from our chairperson?
Yeah, I have a question.
Yes, sir.
Good morning.
Yes, sir.
Yeah, I'm Dr. Shivkumar Yadav. I have a question. Basically, you mentioned the special immunization drive, basically. Na? At that time, Mission Indradhanush was also going on.
Yes, sir.
So it was separate from Mission Indradhanush.
Sir, actually, it's with the collaboration with the health department also. Sir, the workers are migrant from the other district to work in the for building purposes, so they are left out there. So that's why we are organize a special immunization drive for that migrant population, sir. Hello. Sir,
Okay, I'm Dr. Akshay, and I also have one question for you.
Good morning, sir.
So can you tell me what are your inclusion and your exclusion criteria?
Sir, my inclusion criteria, sir, I have taken children less than 5 years of age. And sir, exclusion criteria, sir, I've excluded the children who have uh, their vaccine cards excluded them, sir.
So those who are having the vaccine card, they were excluded.
Yes, sir. Sir, I seen their data कि उनको कौन-कौन सी वैक्सीन सर लगी हुई है, तो उनको एक्सक्लूड किया था सर.
और जिनके पास कार्ड नहीं था, उनको कैसे आपने देखा कि इनके पास वैक्सीन नहीं लगी हुई है?
सर उनके सर पेरेंट्स से
जैसे 5 साल यहाँ लिखा है कि लेस देन 5 ईयर गिवन द बीसीजी.
यस सर.
बीसीजी का कौन सी ईयर तक रिकमेंडेड है?
सर 5 इयर्स तक कर सकते हैं सर उसको.
बीसीजी?
यस सर.
सर जरा थोड़ा सा होमवर्क कर लीजिएगा. आई डोंट थिंक सो. नंबर 1. एंड इफ यू डोंट हैव द कार्ड, देन हाउ यू विल सी कि आप इसको बीसीजी लगा हुआ है बच्चे को कि नहीं?
सर वो बीसीजी के सर वो इंजेक्शन साइट पे सर वो चेक किया था उनको सर, जिनको था सर उनको एक्सक्लूड कर दिया था, और जिनके नहीं सर था उनको फिर बीसीजी वो कर दिया.
तो मेरे हिसाब से आपके रिजल्ट थोड़े ज्यादा बेटर होते हैं अगर आपने सबको हाईलाइट किया कि कितने बच्चे थे, कितनों में से कितनों को लगाया गया. थोड़ा जो चार्ट आपका रिजल्ट्स जो है ना थोड़े बढ़िया होते. ओके, एनी हाउ, थैंक यू.
ओके सर, थैंक यू सर.
Any other question, sir?
No, nothing from my side.
Now I would like to Dr. Harjeet Singh Bivgi. Please start your presentation, sir.
Good morning, ma'am. Hello.
Yeah, good morning, sir. Please share.
Ma'am, actually, before my presentation, there is Dr. Paramjot Bindra's presentation. She is with me. Is it okay if she presents first?
Okay, sir. Let her present.
Thank you, ma'am. Is it visible?
Yes, visible. Visible.
Good morning, everyone. Good morning, respected chairpersons. The topic of my poster presentation is study about the hand hygiene practices among healthcare providers in a tertiary care institute. I, Dr. Paramjot Bindra, working as Operations and HR Manager in Shri Guru Ram Das University of Health Sciences, Shri Amritsar. Introduction. The importance of hand hygiene was recognized as early as 1840s by Dr. Oliver Wendell till now when the COVID pandemic occurred. However, adherence still remains as low as 40% or below in most healthcare institutions. Improper hand hygiene by healthcare providers is responsible for about 40% of nosocomial infections, resulting in prolonged illness, hospital stays, and unexpected high costs on patients and families. Lack of knowledge and lack of recognition of hand hygiene opportunities due to patient care are mainly responsible for poor hand hygiene among healthcare workers. Coming to objectives, aim of the study was to assess knowledge and compliance regarding hand washing procedures in a tertiary care institute. Methodology, type of study was cross-sectional survey was carried out in SDRD hospital in Amritsar. Method was simple random sampling. By expecting the compliance to hand washing in healthcare workers to be 60% with type 1 error as 5% and error of margin of 10%, the sample size worked out to be 90. However, a total sample of 100 was taken for the study. Inclusion criteria, sampling frame consisted of all the healthcare workers involved in patient care in a tertiary care hospital. Exclusion criteria, doctors, interns, residents, specialists, and healthcare working in OT were not included in the study as they form a different group. A questionnaire was prepared based on WHO and CDC guidelines and available studies on hand washing. Results, 45% of healthcare workers were working in a medical ward while the rest were working in the surgical ward. And majority 91% had received training either during their graduation or on the on-job, and the large proportion 81% attended reorientation activities. Level of knowledge regarding hand hygiene immediately before touching a patient or preventing transmission of germs and unclean hands as an important route of cross transmission was high as 85% and 73%. Coming to table number 1, that was scrubbing, hand washing with soap and water, and hand washing with alcohol. No scrubbing was seen during hand washing with soap and water, while 12 followed during the alcohol hand rub. Only scrubbing of palms were not there. In 23, it was there with the hand washing with alcohol-based hand rub. Scrubbing with the wet spaces were there for 13% during hand washing with soap and water, and 4% for hand wash with alcohol-based rub. Covering all parts were there with 87% during hand washing with soap and 61 with hand washing with alcohol-based hand rub. So coming to duration, less than 20 seconds were there for 13% doing with hand washing with soap and water, and 48 with doing with alcohol rub. 20 to 40 seconds were followed by 25% with soap and water and 40 with alcohol rub, and more than 40 seconds were followed by 62% with soap and water and 12% with hand washing with alcohol rub. Coming to distribution of participants according to frequency and reasons for non-adherence to hand hygiene. Frequency 1 out of 5 times were 16, 1 out of 10 times were 3, 1 in 25 times were 19, 1 in 50 times were 27, 1 in 100 times were 35. Reasons: facility not available were said by 35, very busy were 52, facilities available difficult access were said by 5, and facilities not in good condition were said by 11. Coming to discussion, healthcare workers in our study preferred hand washing with soap and water over alcohol based hand rubs, and this was in contrast with study carried out in a tertiary care center in Chennai. Compliance to WHO guidelines regarding adequate hand washing, hand hygiene was higher, 87% for hand washing with soap and 61% for alcohol rub. That was seen in the study done in Ludhiana. 41.3% among nurses working in ICU setting for tertiary care hospital. Lower compliance with alcohol hand wash may be explained by the perception that 85% healthcare workers in study consider that hand rubbing with alcohol-based hand rubs to be more rapid than hand washing with soap and water. The factors for non-compliance in study are in consonance with a review conducted to assess barriers to appropriate hand hygiene. Coming to conclusion, adequate knowledge about hand hygiene was there. However, false sense of security by alcohol hand rubs were seen. A multidisciplinary approach is required to tackle issues of non-compliance. Thank you.
Hello. Hello.
Hello.
If you are able to hear.
Hello.
Hello. I'm Dr. Priyanka.
Hello. Yes. Yes, ma'am.
Yeah, I want to ask a
Good
question.
morning, ma'am.
I want to ask a
Yes,
question
ma'am.
from you. If you also
Yes, ma'am.
inquired about the technique of hand washing.
Yes, ma'am.
Then you have not mentioned that in table. How? What is the number of person which are appropriately doing appropriately following the steps of proper
Ma'am,
hand
actually,
washing?
due to I was not having much space to portray, so that's why I was not able. But if you want, I can share it with you.
Okay. And what is random sampling?
Ma'am, the randomly 100%, like we have around 550 nursing staff working here. So randomly, who's were working in medicine and surgical wards, we were selected those persons.
So how you will do? What is random method? You know how random sampling is done? What is the method of doing
Actually, ma'am,
random
random is
sampling?
some from morning, evening, and night shifts were taken as this in the study. Randomly means जो available है उसको you can have that person.
This is not random. जो available है तो वो तो आपका compliance based हो गया जो available है.
Yes.
Okay.
Okay.
Any other question, ma'am? Sir, any other question?
I have one question.
Yes, sir.
Dr. Paramjot, can you tell me the relevance of this study?
Hello.
Yeah, can you let me know the relevance of this study?
Yes, sir. Sure, sir. So, this study was conducted to see the adequate knowledge about hand hygiene. And moreover, our organization wants to go for the NABH accreditation. So we want to see the compliance rate, how much staff nursing are getting complied with the hand hygiene, and to reduce the nosocomial infection rate, sir. So if they practice the hand hygiene, and moreover, I want to see whether they required more training sessions or not.
Okay, okay, thank you.
Thank you, sir.
Any other questions, sir?
I have one question. Since you have excluded the participants from the OT.
Yes, sir.
Hello. So
Hello.
is it right to collect data on scrubbing, because scrubbing is basically done in OTs?
Sir, actually, for that we need the different study, because in this only I was calculating the hand hygiene and the movements for like they are like for the certificate hand wash you need to have 3 to 5 minutes of hand washing.
That's
So
why
we were taking who are
yeah.
following the basic hand washing. So that's why I excluded
hand washing with water and soap, or hand rub by alcohol based sanitizer. But scrubbing is basically not done in wards. Scrubbing is done basically in OTs, and you have already excluded.
OTs, yes, sir.
Yeah, you have already excluded
in this. Yes,
yeah,
sir.
the scrubbing data is
OT,
not
yes,
necessary
sir.
in this.
Yes, sir.
Okay, thank you.
Oh, okay, sir.
So I would like to request to next presenter, Dr. Harjot Singh Devi. Please start. Please start your presentation, sir.
Good morning, Chairperson. I am Dr. Harjot Singh, Associate Professor, Department of Community Medicine at Sri Guru Ramdas University of Health Sciences. Today, my topic is a study of knowledge, attitude, and practices regarding biomedical waste management among healthcare workers.
Sorry, sorry. Please share your screen first.
Sure, ma'am. Just wait a minute. I need to stop sharing the first, then I can share the other.
No, sir, you have to change the slide.
Ma'am, is it visible?
Yeah, it is visible now. Okay.
My study is on study of knowledge, attitude, and practices among regarding biomedical waste management among healthcare workers in a tertiary care institution. Now, coming to introduction, Sri Guru Ramdas University Institute of Medical Sciences and Research is a tertiary care institution, and it has been selected by UNIDO, that is United Nations Industrial Development Organization, for technical assistance, training, and provision for free infrastructure. Healthcare institutions, they generate biomedical waste which can harm the surrounding environment, cause various infection and injuries to the health workers, patients, their attendants, and hospital visitors. Now, coming to aim and objectives, to assess the knowledge, attitude, and practices among nurses, laboratory technicians, housekeeping staff, nurses in various departments of the hospital. Now, coming to the methodology, it was a cross-sectional study. Sampling method, stratified sampling method was there. Eligibility criteria, all the consenting individuals. Sampling size, expecting that 50% of the study population, they had precise knowledge about the rules and legislation of biomedical waste management, with the allowable error of 10% at 95% confidence interval, and the accounting for the finite population correction for 1700 participants. A minimum sample size of 426 was calculated, which included 138 staff nurses, 35 laboratory technicians, and 253 housekeeping staff. Now, Coming to the results, so as you can see in the first table, it shows out of 426 respondents, primarily housekeeping staff were younger than 30 years, while nursing staff were comparatively of elder age group. Females were predominantly among the nursing staff, that is 93.5%, while the laboratory technicians, they had more respondents who were graduate and above 77%, while all the other housekeeping staff were below graduate. Based upon the years of experience, majority of the housekeeping staff, that is 70.8%, they had a job experience of more than 5 years. Now coming to table number 2. So this shows nursing, first of all, nursing and laboratory technicians, they were combined for the analysis purposes. Nursing and laboratory technicians, they had significantly more knowledge than housekeeping staff regarding the biomedical waste rules. Overall awareness of biomedical waste rules were correctly describing color coding, acknowledging needle stick injuries or consequences were also were found to be statistically significant. Now coming to the practices in the table number 3, it shows that practices that which are being followed by nursing staff and laboratory technicians were considerably when compared to housekeeping staff. The parameters of practice like wearing gloves while handling waste, point source segregation, proper labeling of color-coded bins, ensuring proper closure while handling the biomedical waste, they were practiced more thoroughly by nursing staff and laboratory technicians as compared to housekeeping staff, and the difference was found to be statistically significant. Now coming to the discussion part, more than 90% of the healthcare providers were aware of the biomedical waste management rules, whereas a study conducted in Delhi showed around 3/4 of the healthcare personnel were aware of biomedical waste rules. However, other study carried out by Nirupama discloses that half of the healthcare workers knew correctly about the rules. Coming to the conclusion, nursing staff and laboratory technicians, they had good knowledge, positive attitude, and good practices regarding biomedical waste management as compared to housekeeping staff. Therefore, additional training was required for housekeeping staff. Thank you.
Any questions, sir? Dr. Priyanka Kesavani, ma'am? Any question from Shiv, sir?
Yeah, I have a question.
Yes, sir.
The basis of this study was according to the recent guidelines of biomedical waste or the previous one? Because now, when was the study conducted? Can you tell the year? The data collection was taken place.
It was conducted last year, so in 2019.
Okay. Yeah, according to the recent guidelines, the data collection was done. Recent biomedical waste.
Regarding so biomedical waste rules have been updated in 2018. After that,
Yeah. One more thing I want to suggest: the presentation of your result, the graphs, they need to be a little bit more aligned because we have to tilt our neck to see the graphs.
Okay, sir.
Okay, so next time, if you kindly improve on that.
Sure. Thank you very much, sir. Thank you.
So I have a question for you.
Yes, sir.
Did you find out some relation between the education and the practices, means what they are practicing and their education level?
Yes, sir.
As in your study, I can see that more educated are laboratory technicians as per your studies.
Nursing staff and laboratory technicians. More of the housekeeping staff, they were more undergraduates. Because yes, so I think and they keep on changing, especially the housekeeping staff. So I think so we can plan some training in the vernacular language so they can better understand what are the biomedical waste rules and how to handle, because ultimately they have to carry it from the wards ultimately to the storage area. So we think more training is needed part, and especially in the vernacular language, I guess.
That's the point. Okay, thank you.
Yes, sir.
Okay, our next presenter is next and last, Dr. Chaudhary.
Thank you, ma'am.
Hello? Hello, am I audible?
Yeah, you are audible, ma'am. Please share your screen.
Yeah, just a second.
Dr. Purvita, please start your presentation.
Okay. Good morning, everybody. This is Dr. Purvita Chaudhary from Tripura, and my presentation today is about childhood immunization and morbidity in Tripura, a comparative analysis with National Family Health Service data. So, the childhood health status, including immunization and morbidity management, comprises an integral part of Indian primary healthcare programs. So, therefore, periodic representation of health indicators has been also reported in the National Family Health Service and also in district level household surveys over the last 2 decades. But, however, substantial disparities are seen among the states and which are very evident. Therefore, the present study was undertaken to understand the trends and transitions of this childhood health status over the last decades in Tripura. Coming on to the materials and methodology, the study was a cross-sectional study which was done in 2017 in Tripura. And the inclusion criteria were we included children of up to 5 years of age, and then data accumulation was done from NFHS and DLHS. Data on children and immunization, data on children immunization and common morbidity was extracted, and then comparison was done using statistical analysis using chi-square test. So coming on to the results, among the surveyed 239 children, around 80% received complete vaccinations as per the universal immunization program. So here we found that 4.4% were non-respondents, and however, 23% 23% of the local indigenous children and 16.4% of the non-indigenous children were partially vaccinated. So, and we found significant difference between BCG dose, uptake of BCG dose among indigenous children and non-indigenous children. And there was also significant difference in deworming tablets receiving among the indigenous and non-indigenous children. So, if you can see the graph, I don't know if it is visible or not, but there was a drastic change in the data since the first NFHS data and our data, which was collected in 2017. There was almost 1.4 fold change since the last NFHS data that was in 2015-16 in NFHS 4, and in our data we see that the all vaccinations has been received for up to 80% of children. Now, if you see another health indicator, that is the childhood diseases, we see that there was an increase in childhood disease in fever since the last NFHS data. Similarly for ARI and also for diarrhea. So one thing we can say here is what we have observed here is there is an improvement in the vaccination as per the existing government programs in Tripura. But however, the childhood diseases still remain pretty much evident from the whatever is available data. So what we can recommend here is very important is the IEC and awareness activity is very important for vaccinations, as in local languages, and also integrated management of neonatal and child illnesses, that is IM and CI for management, needs to be promoted at the grassroots level. Thank you. Hello. Hello.
Yeah, thank you, Dr. Purvita. Can you just tell me what was the source of your data? You are seeing our data.
Yes, yes. Sorry, I forgot to mention about this. Actually, this was a study, a small part of the study that was a part of a larger multicentric national task force study of ICMR that was conducted. So Tripura MRHRU was a site for this study as well. So here, so that is what I'm referring to here.
Any other questions, sir?
I have a question.
Yes,
What do you mean by indigenous and non-indigenous children?
So indigenous, I am referring to here as the tribal population, and non-indigenous as the non-tribal population. In Tripura, there are about 19 tribal tribes. So I'm referring to the tribal population of this region.
Okay. One more suggestion I want to give. Basically, you have compared the vaccine coverage
Yes,
with certain diseases of the childhood.
So I have compared. I have compared, like for health indicators, there are different indicators of child health indicators, like your nutrition, immunization, and your childhood diseases, etc. So I have only taken the immunization and the childhood diseases here.
One more thing that could have been done if you have compared with the vaccine preventable diseases, VPDs.
Okay.
Then that can be also be added so that we can
So
basically correlate.
actually we also have data for vaccine preventable diseases like measles also. So that was also included in the study, but since we did not get any significant difference, so I have not shown here in the graph.
Because as per your study, it is showing that the vaccination coverage basically is increasing year by year. So if that can be correlated with the drop in the vaccine preventable disease in Tirupura, that can show that vaccines are basically vaccination. It is basically working. So that could have been done.
Okay. Thank you, sir. Okay.
Any other questions for ma'am?
Hello.
Yes, ma'am.
Hello. I want to ask what is the percentage of institutional delivery in your study? Because no child is getting the BCG vaccine at birth. You have mentioned that, na?
Yes, ma'am.
So what is the reason behind that?
Ma'am, what we found in the study, like BCG vaccines, they were incomplete vaccination, there were 5% that was seen, and mostly the reason when we asked about it, it was because of unawareness. So these pockets are like they are very far off in the rough terrains, which is very much inside in the tribal areas, and they live on the hilltops, so which is very difficult for them to come down and then reach the hospital. So mostly they are unaware, and the main problem is here because of the dialect. So there are 19 tribes which have their own dialects. So making them aware in their own dialects is very essential, what I think. And therefore there is but now they have increased the institutional delivery with the help of ASHAs and MPWs, but initially it was very poor.
But sorry, but you have mentioned the immunization coverage is above 80%, 85 something.
Yes. Now it has increased.
If coverage is
uh-huh.
coverage is too good, and it means ki institutional delivery percentage is also very low.
Yes, ma'am.
Okay, if you have proper information
Because
regarding that or not.
No, no, ma'am. What I'm saying is institutional delivery is being done, but there are what we found in the field is they are unaware. Some they do, some there. As I said, there are only 5 people who have who did not go through the complete vaccination, who do not have complete vaccination. So first of all, they are unaware. Then there is they are also they have this fear of this of side effects. So that is what I'm saying.
Side effects.
Yes.
Okay. Okay. Any other questions, sir? Any other questions from any chairperson?
No, thank you.
Okay. So we have
Thank
done
you, ma'am.
presentation. So our most sincere thanks to our chairperson, to our presenters and all the delegates for their support and for sparing so much time for us. Thank you so much, sir.
Thank you.
Thank you.
Thank you so much.
Sorry for the inconvenience. We are dealing on network issues, so we are connect soon. Oh, sorry for the delay. It's our network problem and personal issues on laptop. So, good afternoon, respected person, chairperson, and speakers. Now, I would like to now I'll introduce our first speaker, ma'am, actually Dr. Deepika Agarwal, professor and head of community of medicine, Santosh Medical College, Ghaziabad. Second chairperson is Dr. Tanvi. He is a scientist in B in medical fertility, and Dr. Dakshan Hali, the assistant person in community and medicine in GMC. So now we're gonna start our first presentation. Dr. Sandhya.
She's going to speak on.
She
Yes,
is
sir.
gonna speak on the study on knowledge, awareness, attitude, and behavior about the BMW among the house. Dr.
Over to you, Sandhya.
Over to you, Dr. Sandhya.
Please share your
Yes, sir.
screen.
Sir,
Share your
thank you,
screen,
sir. Yes, sir.
Dr. Sandhya.
Yes, sir. Just a minute, sir. I'm sharing my screen, sir.
Speaker can speak.
So the document is not supporting, sir. So can you share, sir?
Try to say there's an option in there. Try to say, ma'am, please.
Yes, sir. Yes.
Actually, my system is
Yes.
not working. That's why.
Yes, sir. Yes, sir. I'm trying, sir. Actually. So, so it is not coming, sir. Actually. So just I'll try it, sir. Again.
You will take time.
Yes, sir. Yes, sir. Yes, sir. Yes, a little bit, sir. Sir, it's okay. I'll continue as the next class, sir. Just in the meanwhile, I'll just make it set.
I'll continue to Dr.
I'll
Chaya.
do.
Okay, now I'll
Yes.
continue to Dr. Chaya because he will join later, na?
Yeah.
I will
Yes, sir.
request Dr. Chaya, ma'am, please present your e-poster on this and share your screen.
Yes, sir, but sir, I am not able to also share, how to share screen because sir, I am just trying to share, but I am not able to share it my screen.
See, there's a green color
Yes, sir, I have done. I
on
have.
your screen.
Sir. So yes, I have opened that green sharing is green dots. So I am just there is just showing some box photos documents. So sir, where should I go for after that? And screen also. I'm just trying to share screen.
Dr. Sandhya.
Sir, even I am trying that, sir. It is not. It is asking for to show in a PDF form, sir. Actually, I'm having in PPT form, sir.
Hello.
It's okay now, but you'll try. But you have to do your
Just maximize it.
just maximize it.
Hello.
Hello, ma'am. Just maximize it and show it your presentation to our respected chairpersons. They are waiting for your e-posters discussion, please. Dr. Sandhya, please be ready for your presentation, please.
Dr. Chaya, we can see your screen, but you need to maximize it. It is visible, but just maximize your screen.
Dr. Sandhya, can you continue? Dr. Sandhya, Dr. Chaya, Dr. Sneha, you are ready for your presentation? Uh, Dr.
Yeah,
Chaya,
I'm ready.
Dr. Sneha, you are ready for your e-poster presentation?
Yes, yes,
Could
yes, I'm ready.
you
I'm
start
just,
your then? You,
yeah, I'm just sharing my presentation.
okay, ma'am. Kindly enlarge that.
No, it is not mine. It is Dr. Chaya's presentation, I think.
Yes, ma'am. This one, Dr.
Dr. Chaya is trying, I think. It is Dr. Chaya's presentation, I think. She's presenting. So I should unmute myself, mute myself. Dr. Ankit?
Yes, ma'am.
Yeah, I am just muting myself.
Okay, ma'am. Okay. Now Dr. Chaya will represent.
Yes. Good afternoon to all.
Dr. Sandhya will continue later. Now I'll request Dr. Sandhya ma'am to continue. Sneha, to please present your e-poster. Dr.
Okay,
Sneha.
okay, Dr. Ankit, I'm
Because
just
our
sharing my
chairperson
screen.
is waiting for us.
I'm just sharing my screen.
Yes, ma'am, please.
I'm just enlarging it. Is this visible to all?
Yes, ma'am. It is visible for everyone.
Okay.
You can continue.
Okay. Good afternoon, everyone. My topic of poster is Holistic Health, an Approach to Life, Public Perception Survey among General Population of Delhi, India. As we all know that holistic health is an integrated model for provision of physical, mental, social, and spiritual health. So it consists of body, mind, and spirit as a single unit. So my aim and objectives of carrying out of such a study is to assess holistic health concepts and practices among general population of Delhi. It was a community-based cross-sectional descriptive study of 1 year. It was conducted in South Delhi. People above 18 years of age residing in South Delhi for 6 months or more. 6 areas were randomly selected from South Delhi by lottery method, and from each area, first 70 people who met our inclusion criteria included in the study. Sample size was calculated using EpiInfo software version, taking the population of South Delhi as approximately 2.73 million and prevalence 50% with 5% acceptable margin of error and 95% confidence interval. It came out to be 384. Study tool was pre-tested semi-structured interviewer-based questionnaire taken as per standard questionnaire from American Board of Holistic Medicine. The questionnaire consisted of three domains: body or physical health, mind or emotional health, and spiritual health. And in that table, Optimal health, excellent health, and good health are categorized as above satisfactory health. Fair health was categorized as satisfactory health, and below average health, poor health, and extremely poor health was categorized as below satisfactory health for the point of analysis. Data analysis was done in an MS Excel and then analyzed in SPSS version 23. Descriptive analysis was done by using calculating proportion, mean, and standard deviation. And association was established by using chi-square test. Ethical approval was obtained from institution ethical committee. Informed oral consent was taken from each participant. Now results of this study. As we can see that table number 1, if we see the socio-demographic profile of a study population, most of the study population belong to 31 to 60 years age group. Males were more in our study. The illiterate were a few up to primary school, where majority were up to senior secondary school. Hindu were more in a percentage of 83%. And most of the many participants were working, that is 68.2%. Now distribution of study population based on composite scoring, as we can see that 21% were above satisfactory health and 48, nearly half, that is 48.7% were satisfactory health, and below satisfactory health were nearly 30%. Now, if we see the association of health status with socio-demographic variables, now we can see that males were having lower satisfactory health than females, maybe because of they are engaged in outside activities, and for earning purposes they are not putting so much care on their health. If we see the age group, we can see that as the age increases, level of health also increases, and it was found to be statistically significant. And also, if we see that as the education increases, level of health also increases, it was also statistically significant. And among Hindus and Muslims, it was found that Muslims were having more better level of health as compared to Hindus. And among working and non-working, there was not any significant association. So based on these results, we can see that males, younger population had better, females, younger population are having just better health scores of holistic health. And as the education status improves, then the scores of holistic health also increases. And I want to conclude that it is high time that concept of holistic health should be disseminated to general population, so that people can understand physical, mental, social, and spiritual health as single entity, and more comprehensive health promotion programs should be planned at community level to reach our general population. Thank you.
Thank you so much, Dr. Sneha ma'am. It is very nice. Now I'd like to call Dr. Sandhya. A chairperson, if you ask any question to Dr. Sneha, you can ask.
Yeah, Dr. Sneha, I have a few questions for you.
Yeah, ma'am.
Yeah, can you please share your screen again?
Okay, ma'am. Just share.
I just want to bring your attention to your table number 1, in which you had shown the socio-demographic distribution of the population you studied.
Yes, ma'am. I'm just sharing that. Yes, ma'am.
Yeah, here you have shown that majority of the population was above 30 years of age, है ना? And but you said that males were, the proportion of males was 65% in the studied population.
Yes,
did you conduct this survey? It was a house-to-house survey, or in what manner was it conducted?
Ma'am, it was house-to-house survey, ma'am.
And it was conducted in 2019, right?
Yes, ma'am. Yes, ma'am.
So,
but ma'am,
yeah.
But ma'am, I conducted.
How come you found?
I conducted surveys on holidays and Sundays, so that I can find a whole family inside the house. As the earning population. Yes, ma'am. Please, ma'am.
Yeah. So did you just took the interview of the head of the family, or In what way did you select the respondent?
Ma'am, head of the family. Because head decision of the head of the family applies to all the family, other family members. So I tried to just take interview from head of the family, ma'am.
Okay. Another thing that you, in your table number 3, you said
Yes,
that
ma'am.
Muslims had a better level of health as compared to Hindus.
Yes, ma'am.
However, the proportion of Muslims in your study population was only 10%.
Yeah, ma'am. Yes, ma'am.
So, can we say that Muslims, for sure, I'm not sure. So
Ma'am, you are absolutely right. Since percentage of Muslims were less in my study, but ma'am, when I administered my questionnaire to them, I saw that spiritual component and that mind component were more scored more higher scores than Hindus, because they used to do namaz and so many, so they scored better than Hindus, ma'am.
Okay. Okay, that's all.
Okay, thank you, ma'am.
Now I request to Dr. Sandhya, ma'am, kindly present the e-poster. Dr. Sandhya, are you ready for your? Are you ready?
Excuse me, Dr. Ankit.
Yes, ma'am.
Yeah, I'm yet to receive the Google forms. I haven't received your link for the
Just I
Google
send
forms.
you, ma'am. Just within
Okay.
1 minute, I will send you.
Same with me, Dr. Ankit. Even I have not received any Google Forms for marking.
Ma'am, within 5 minutes, I'll send you after that.
How many speakers have already presented?
One only. Right now, 2 is left, ma'am. Dr. Chaya and Dr. Sandhya is left.
Okay, fair.
Dr. Sandhya. Dr. Sandhya, are you ready? Dr. Chaya Bora. Anyone can present? Dr. Sandhya.
Can you see my screen, sir?
Yes,
Sir,
it
this
is
is Dr.
visible.
Sandhya, sir.
Yeah, it is visible. Now
This
you
is
enlarge
sir.
your screen and kindly enlight
Yes, sir.
us.
Is it okay, sir, now? This was okay, sir. Was it okay, sir? Is it okay, sir? Hello?
Enlarge according to the
Hello?
person. Please enlarge. It is not clearly visible to our respected speaker, ma'am.
Yes, sir. Yes, sir. I can understand, sir. But it is coming. Is it okay now, sir? Is it okay now, sir?
Not, it is not clearly. The words are missing from the introduction part. You have just read, and now Deepika ma'am, Darshan Wali ma'am, and Tanvi ma'am will see. I just
Oh.
wait. I'll do something for you. Now it is good, visible. ये इसको शेयर करना है, कैसे करना है ऋतिका? Now it is visible for
Is
you,
that okay,
everyone.
sir?
Just wait. I'll do something for you.
Should I stop?
ये नहीं आ रहा ना अभी.
Yeah. Yes, sir. Yes, sir.
No, I'll also now. Just give me 1 second. बड़ा साइज बड़ा सा छोटा करना पड़ेगा. और करो. बस. It is visible for every respected speaker. It is visible for. Hello.
Yes, sir. So a little
That
bit.
is visible for everyone now.
Yeah, it will do, I think.
Yeah.
Yeah, it's visible. Yeah.
I request to Dr. Sandhya, please continue.
Yes, sir. Just yes. So good afternoon, one and all. This is Dr. Sandhya. I am from Kaminani Institute of Medical Sciences, Telangana. Today, I'm going to present about knowledge, awareness, attitude, and practices about the biomedical waste management in house surgeons in a tertiary training center. So coming to the introduction, biomedical waste management is a hazardous and can lead to the many infections or diseases. Interns are the future physicians of tomorrow, and they should be conscious about safe disposal and segregation practices. So the present study was taken to assess the knowledge and awareness about the biomedical waste management in interns. So my aim is to assess the knowledge, awareness, and practice of the biomedical waste in house surgeons attending to the Rural Health Training Center. And my study setting is the Rural Health Training Center of Nalgonda district, which is a rural area. And it is a study population are the house surgeons attending to the training center. And my inclusion criteria are all the house surgeons who are attending to the Rural Health Training Center. And it is a cross-sectional study, and I have taken 100 house surgeons for a period of 6 months, those who are attending to the Rural Health Training Center. And it is a semi-structured questionnaire was given to collect the data, and it was analyzed by using the Excel. And ethical consideration was taken from the KIMS ethical committee, and the permission from the principal was taken. And coming to the results, coming to the knowledge, 94% had the knowledge of biomedical biohazard symbol, and 43 of the house surgeons are aware of the authorization, and 52 of the house surgeons are about special permission is needed for the transportation. And coming to the awareness, 31% are aware about the general waste, and 61% are about the color for the sharps, and 7% are aware about the percentage of the infectious waste is produced. uh, Attitude and the behavior, 61% are following the color code, and 35% follow the general waste in black color bag, and 33% are having the attitude of the maintaining the record, and 46% are having the attitude about the disinfection of the liquid waste. Here, these are the bar diagram showing the knowledge, which is showing the 43% about the legislation, who are knowing about 43 members are knowing about legislation, and 52 members know about the regarding permission for the transport, and 30 members were know about the agency, which agency is working under the for biomedical waste management. And here the awareness table showing the color code. In that color code, only 61 members know about the white is used for the shops. And here we can see only 7% of the people know, house surgeons know about the 10% of the infectious waste is delivered from the biomedical waste management, biomedical waste. And here the color used for the general waste, only 31 members know said about that black is used for the general waste. And here the in case of attitude and behavior, 46 members they are having the attitude about the disinfection of the liquid waste, and 43 members are knowing telling about attitude having about the maintenance of the register, and 72 members they are accepted for needing for labeling of the containers, and 35 members following the general waste for black color code bags, and 61 members following the color code. Coming to the conclusions, although respondents bear the good awareness of biomedical waste and its health hazards, but correct knowledge of biomedical waste management needs strengthening. This emphasizes the importance of training regarding the biomedical waste management. Lack of proper and complete knowledge about the biomedical waste management affects the practices of appropriate waste disposal and jeopardizes the health and environment. Coming to the recommendations, the resident doctors should be trained in biomedical waste management. Time to time assessment of knowledge and skills need to be emphasized. Yes, ma'am.
Thank you, Dr. Sandhya. Now, chairperson can ask the questions to Dr. Sandhya.
Yes, sir.
Yeah, Dr. Sandhya?
Yes, sir. Yes, ma'am.
Yeah, the title is Knowledge, Awareness, Attitude, and Practices. So, how did you differentiate between the knowledge and awareness?
Is knowledge is the thing about what they know, ma'am. Awareness is the it is the
Hello,
ma'am. Is it audible, ma'am?
yes, yes.
Awareness is it is the sense of data which will be confirmed by the
इट्स द
observer,
सेम
ma'am.
मेरा व्हाट्सएप नंबर यही है जिस पे आप मुझे फोन कर रहे हैं ओके 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 ओके
Are we done with Sandhya?
Done?
Yes, ma'am.
Done,
Yes.
Dr. Sandhya?
Yes.
Now I
Yes.
request Dr. Chaya Bora to kindly present their e-poster.
Dr. Ankit, I have a question for Dr. Sandhya.
Ma'am, please ask. Yes,
Yes, ma'am.
please.
Yes, ma'am.
Dr. Sandhya, I just wanted to know the questionnaire that you have used. Like, how was it prepared? How was it validated?
Actually, it was a semi-structured questionnaire, ma'am. We in that questionnaire only a few questions will be. It is not like completely formal data, formal questionnaire, ma'am. Ma'am, like regarding knowledge and attitude and awareness, we have asked the questions, ma'am. Ma'am, hello.
Dr. Sandhya, yeah, you have not asked any questions about practices.
Yes, ma'am. Asked ma'am about the color code, what they are following regarding the for general waste and regarding for the color, what they are using for the sharps and all.
No. You have not shown any table in your results related to practices, or am I not able to see it?
Bar diagram. This is the last one, ma'am. Actually, this
Figure
in this
2.
attitude and the behavior. Yes, ma'am. Yes, ma'am.
This is attitude and behavior, no?
Both in both both I
Okay,
have
okay,
included
okay.
in this, ma'am.
Okay.
Yes, ma'am.
Okay, fine, Dr. Sandhya.
Okay, ma'am. Thank you, ma'am. Thank you.
Now I'd like to call Dr. Chaya Bora, ma'am, please. Dr. Chaya, kindly present your e-poster. Dr. Chaya, I'm audible to you. Dr. Chaya, I'm audible to you. Yes. Kindly enlarge, ma'am, kindly enlarge that poster. मेरे पास पेपर शेयर कर देता हूँ है मेरे पास Dropbox में होगा।
Haven't they prepared it on PowerPoint?
Dr. Chaya, it is visible for you. Dr. Chaya. रुको नहीं रुक जाओ डॉक्टर छाया इट इज विजिबल फॉर यू डॉक्टर छाया पे स्टार्ट करें डॉक्टर छाया
Dr. Shaya,
कॉल करो प्लीज नॉट Dr. Chaya, मैंने आपके लिए presentation का you can speak.
Kindly start presenting.
Please speak. Dr. Chaya, could you speak, please? Our respected chairperson are waiting for you. Dr. Chaya, could you start once?
Dr. Chaya, you are not audible. Please unmute your mic and now speak.
Dr. Chaya, there's a very late time because we have to attend various sessions. Please unmute yourself and start presenting your e-poster presentation. Our panelist is waiting for your.
Dr. Ankit, do we have another presenter?
No, ma'am. We have only three presenters for the
Can you
today
please
session.
call Chaya on her personal number and tell her to? I
Okay,
don't know
ma'am.
why she's not able to do it.
Ma'am, there is a network issue with Dr. Chaya. She will continue soon, ma'am. I just call him,
Okay.
her, and she will attend soon.
Dr. Ankit,
Ma'am,
hello. Dr. Ankit, can you please tell me the registration numbers of Dr. Sandhya and Dr. Sneha?
ma'am, Dr. Sandhya registration number 330, Dr. Sandhya,
330. Yeah.
and Dr. Sneha 283.
283. Okay, thank
Yes.
you.
And ma'am, Dr. Chaya is 324.
Yeah, that I can see. Yeah, thank you.
Dr. Chaya, everything's Dr. Chaya, I'm audible to you. Kindly unmute yourself and start presenting your PPT. Dr. Chaya, you're not audible still. It's a less time for us. Time moderated. है.
I think if she is not able to join by 1:30, we will just, no, we should
Ma'am,
just.
we can do one thing. Now we'll bind up with the only two presenters. So, nahin, she's not.
Yeah, let's wait till 1:30. If she is not able to join, then we can just mark the other two presenters, right?
Yes, ma'am. We will wait for 1:30, ma'am.
Yeah.
Respected chairperson, one more candidate will be added soon, Dr. Vinita Kotalia.
Okay.
अब फोन करो और पूछो अब करो विनीता को।
Dr. Vinita, I'm audible to you. Dr. Vinita, I'm audible to you.
Yes, sir, I can hear you, sir.
Please kindly present your e-poster, please.
Okay, sir. So good afternoon, everybody. I'm Dr. Vinita, and I'll be talking about a review of 108 services in the state of Uttarakhand. So the aim of our study is to review the emergency services provided by CAM via 108 services with respect to total number of calls and emergency
Dr.
calls.
Vinita, kindly share
Dr.
your screen.
Vinita, we can't see your presentation.
Okay, I'll just share it. Okay, ma'am. Now can you see, ma'am?
Yes, now it is visible.
Okay. So I'm Dr. Vinita, and I'll be talking about review of 108 services in the state of Uttarakhand. As we all are very well aware of the geographical location of the state of Uttarakhand, that due to hilly areas and far-off areas, people have to face several problems regarding health facilities, especially the pregnant females. They have to travel a lot to get the proper services at time. So, considering this, the government of Uttarakhand has in year 2008 have collaborated with GVK EMRI for landing 108 emergency services, and now recently last year May 2019 it has been handed over to a non-profit organization, that is CAM. So I have the objective of this study is to review the emergency services that is provided by CAM, and to study the response time of service provided by CAM, and to compare and contrast the services provided in various districts of Uttarakhand. So it is a retrospective study, record-based study done in state of Uttarakhand from May 2019 to January 2020. The data was procured from office of CAMP, that is in Dehradun, and data is entered in Microsoft Excel and then analyzed using the latest version of the SPSS. So here's the first table showing the total number of different type of calls received. That is around 8,49,000 calls were received in the period of this 9 months. Out of these, only 14% were the actual emergency calls. That is around 1,16,000. And out of these calls received, only 86,000 emergencies, 86,245, that is 74% of the emergencies were attended. Rest of the emergencies were police cases and fire cases. And if we see, out of these emergencies that have been attended, majority were the pregnancy related emergencies, nearly about 38%. And out of these pregnancies, 419 deliveries were to be conducted in the ambulance due to various reasons. And if we see the average handling time, the time from the reception of call or from the time of notification of an emergency to handling of that emergency, it is the areas of Uttarakhand are divided into plain areas, middle Himalayas and upper Himalayas, and the time taken was minimum in the plain areas for the obvious reasons. And if we see the average response time of the urban and rural areas, the average response time is again the time taken from the notification to the time by which the ambulance reaches at the spot. So we have seen a decline in the time, that is the average response time is improving over the period of time since last 9 months. And if we compare district wise the data, the maximum number of emergencies that have been attended were in this district of Dehradun, and the minimum were in Haridwar and areas like Bageshwar and Champawat. So this is a district-wise distribution of the cases that have been attended. So maximum have been attended in Dehradun, Haridwar, Nainital, Udham Singh Nagar, and minimum in areas like Champawat, Bageshwar. This could be explained due to the geographical location of the areas and the availability of the ambulance services in those areas. So I would like to conclude that we have seen in this record-based study that there are majority of the calls which were left unattended. So the cause mainly were the unavailability of the ambulances, or either due to delay in reaching of the ambulance services due to the geographical conditions of that area. Hence, we need to increase the number of 108 ambulances. And as we have seen that majority of the emergencies were pregnancy related, and some of the deliveries were to be conducted due to urgency in the ambulance only. So we need to have proper and time to time training of the emergency technicians, those who go in the van. And we have seen that the areas like Haridwar, which are plain area, which comes under the plain area, there is very minimal number of the emergencies that have been called or attended. So maybe that is because of the awareness that is less in the people about the 108 services. And I think better GPS tracking systems and mobile apps for the callers should be there, so that they can timely trace and predict the time of arrival of the ambulance, and they can wait or take another route for handling those emergencies. So I would like to end my presentation. These are the references. Thank you very much.
So, any questions for the Vinita Kutil ma'am? Speakers, can you ask any questions?
Ankit, wasn't it supposed to be a poster presentation?
Yes, ma'am. Actually, I will share a poster. Sorry, I was presenting so that it is easily visible for you all. So I'll just share the poster here.
Because it's a poster.
And Vinita, why have you used secondary data? Why is it a record-based survey?
Ma'am, actually, I went to the camp office. I was just interested in knowing what is the situation right now in the Uttarakhand. And this is just a baseline study. Further, I'm planning to have some study about the different cases and why, about the finding, how these findings are coming, that why in such areas like plainer areas also we are receiving less number of calls and all that. I was just curious and wanted to know the baseline.
Because that you'll come to know only when you have a one-to-one interaction with the people who are involved, like the patients.
Yes, ma'am.
Or the
Yes,
attendants, right?
Yes, ma'am. You're right, ma'am. Actually, I didn't have much idea, so I just wanted to have the idea. So I took the record first.
All right.
So I looked at the records and I have found some. I have some baseline questions for my next research, I think.
Yeah, you can
So
do
I
that.
would like to go further, see what are the reason for these findings.
Okay.
Yeah, one thing I want to just clarify, Dr. Vinita.
Yes, ma'am.
In your presentation, the graph that you have shown regarding the areas from which the calls were received, can you
Yes, ma'am.
slightly enlarge the presentation?
Okay, ma'am. Ma'am, shall I go to the? Okay, just ma'am.
Yeah, just show me the graph, district-wise cases, you know.
Okay, this ma'am.
Yeah.
Any other questions, ma'am?
Yeah, here you have said that Nainital.
Just a second, ma'am. Yes, ma'am.
Yeah, here you have said that Nainital, Hardwar, and Dehradun were the places from which maximum calls were received, right?
Ma'am, actually, maximum number of emergencies that have been attended. Yes, ma'am.
Yeah, and Hannah. So
Yes.
then, in your conclusion, you are writing that the awareness regarding the emergency services was poor, was found to be poor in Haridwar.
Actually, ma'am,
How does that correlate?
Ma'am, actually, if we see, this is the number of emergencies that have been attended. So the number of emergencies that have been attended are really good in Haridwar. But if we compare it with the total population of Haridwar, so it is more than that of Dehradun. So in spite of the bigger population, we are receiving lesser number of calls from Haridwar. So maybe the people they are not either they are not very well aware, or they are not accepting 108 services. They are not comfortable with those services. So I would like to further research why is this finding coming in spite of being a plain area and nearer to Dehradun. So
Okay,
I
and
have
these services are only for government facilities, I guess?
No, ma'am. Actually, they are sending patients to private places also. Mostly to the nearest possible PHCs and CHCs and district hospitals. They are sending the patients, but in cases of emergency, they are taking help of some private institutes or private tertiary care hospitals. They have also taken into their thing.
Oh, okay.
Yes, ma'am.
Maybe that.
So this is basically
Okay,
the
fine.
number of the emergencies that have been attended, but the percentage is minimum in Haridwar because the total, if we compare it with the total population of Haridwar, we see that is even more than Dehradun. So if we take a proportion, it is coming really less. So that is what I'm inquisitive about, and I think I'll be going for further research about this.
Yeah, I think there is a lot to be explored yet in the
Yeah, ma'am.
study.
Yeah, ma'am. That is why.
Okay. Anyway, good presentation.
Thank you so much, ma'am. Thank you so much.
Dr. Vinita, one of your conclusions says that there is a need to increase the number of ambulances.
Yes, ma'am.
So have you been able to get the data for number of ambulances in the districts?
Ma'am, actually not exactly district wise, but in total in Uttarakhand, we have nearly about 300 ambulances that are going in where, because some of them are not in very good condition, and especially going to the higher hilly areas. Some of them, they are old ambulances, so they are not working properly. So the number is around 300, but the exact working ambulances is even less. And I have been told by the people where I contacted and I asked about the work, how they do, the camp office. They told that the number of ambulances, because they are receiving number of calls, but they cannot attend all of the calls because they are short of ambulances. So I think the proper care of the ambulances is very necessary, the maintenance part, because they have number of ambulances, but not all of them are in a working condition.
Okay. And like, are these ambulances segregated according to the districts, or how does that work? I'm
Ma'am,
curious about
actually,
that.
yes, ma'am. They have a full protocol that to rural areas they have certain amount of ambulances, and in higher hilly areas they have. But I have not gone into the detail of those yet. But I think
Okay.
yes, ma'am.
In your next maybe further studies, you could
Yes,
explore that.
yes, ma'am. Definitely, I would like to do that. Any further questions, ma'am?
Any other questions, ma'am? Can we conclude for the other session?
Yeah, sure.
Yeah,
Dr.
sure.
Chaya, last chance, if you want to present Dr. Chaya, you'll continue or will you go for the three? Dr. Chaya.
Thank you so much.
Ma'am, Dr. Chaya. Dr. Chaya. Ma'am, it's over, ma'am, now. We go for the three peoples only.
Okay.
Deepika ma'am, Tanvi ma'am, Rakshan Ali ma'am.
Okay, thank you, Dr. Ankit. I think we will just mark the scores for each
Only
of the
three people, ma'am.
candidates. Yeah,
Yes, ma'am.
yeah.
Thank you, Dr.
Thank you,
Ankit.
Mr.
Thank you, presenters. Thank you, ma'am.
Dr. Vinita, could you let me know your number, registration number?
Ma'am, it is 67.
Okay, thank you.
Okay. Thank you, ma'am.
Okay, ma'am, can we stop here? Now, आप mark करके मेरे को भेज देंगे, ma'am. Okay.
Sure, thank you, Dr. Ankit.
Thank you so much, everyone, for your patience and your time and valuable things. Thank you for making
Thanks,
our
Ankit.
e-poster affordable. Thank you so much, speakers, for your questions and for your time and everything. Thank you so much, chairpersons. Thank you so much.
Thank you.
Okay, thank you. Bye bye.